My name is Professor Dr. Atif Ikram. I'm the head of department at University of Lahore Teaching Hospital. I've done my AUD from Auditory University, Arizona School of Health Sciences, United States of America. I'm board certified in audiology from the United States of America and fellow American Academy of Audiology. I've also done my medical degree, MBBS from Allama Iqbal Medical College, Lahore. Today, we are going to discuss a very important topic in audiology, which is called auditory brainstem response test. Auditory brainstem response test is important because it's a test which is done to diagnose a number of things. Number one is the hearing threshold of children, of infants, of neonates, and children who cannot do tests, pure tone audiometry, and are unable to give a subjective response. Moreover, is also done in patients who are mentally challenged or have some other disability by which they cannot themselves tell about the thresholds that the sound that they are hearing. In that test, an objective test of auditory brainstem response test is done, in which, as you can see in the picture, surface electrodes are placed on the head and mastoid region, and also two insert phones in each ear are inserted for the child to or anyone to hear the sound. The test can also be done through headphones, and bone conduction testing is done by bone attenuator. The learning objectives of this subject of this topic for the students is that they will know Moller's major findings. Student will also know the region of wave 1 to wave 5, which is the most important aspect of the ABR. Students will also know some of the imaging issues that are involved regarding ABR. Students will know the effect of cochlear hearing loss on ABR. That is the mainly why ABR is used in children to get the cochlear hearing loss diagnosed. First of all, we come to Moller's findings. Moller's first major findings were in ABR were intracranial recordings, as we saw that the electrodes are placed and headphones on the ear. For humans was that wave 1 and 2 were both generated by the auditory nerve. So as the auditory nerve leaves the cochlea, it produces wave 1. In other words, the distal part of the auditory nerve, or vestibulocochlear nerve, as it is called, or eighth nerve, produces that. Then it enters the brainstem. Wherever it enters the brainstem, that produces the wave 2 of the ABR. So these were some of the findings of Moller. Then when wave 1 appeared to be generated by more distal aspect and wave 2 by the more proximal aspect of auditory nerve, as I just explained. Moller's recordings from near the cranial nerve indicated that it matched in latency of wave 3 of extracranial ABR recordings. And more recordings led to conclusion that wave 3 in humans is also cochlear nuclei generated. So cochlear nuclei generate wave 3 in our findings. We see that the third wave is generated by superior olivary complex. And then wave 4 is generated by the inferior colliculi of the brainstem, and the wave 5 is generated by the lateral part by fibers of the lateral lemniscus as they enter the area of the brain. The imaging issues. There is and should be this generation of ABR makes it a very good mode of screening for acoustic tumors in present day medicine. With this, we come to the imaging issues. Acoustic tumor, as in technical terms, is called Schwannoma. It is a benign tumor of the Schwann cells of the 8th nerve. That is why it's called a Schwannoma. And the danger it produces is not through being any kind of cancerous issue, but because of the size. As it grows in size, it causes the problems of hearing loss, tinnitus, and possibly vertigo if it goes towards the forms a CPA tumor, which is a cerebropontine angle tumor. So acoustic tumors are relatively rare occurrence. Reportedly, about 1 in 100,000 in the general population, as reported by Cochlear et al. In 1992. So it is a rare phenomena, but one of the retrocochlear pathologies, it is most commonly diagnosed by audiologists. The generator sites we've already discussed. However, when a patient comes to you, now we are going towards the clinical aspects of acoustic tumors, that what is the first, what is the history and the audiometric findings and the findings done through other tests that make us go towards a differential diagnosis of acoustic tumor or acoustic Schwannoma. A major red light for acoustic tumors is if it's a unilateral sensory neural hearing loss in adults. And a key factor for MRI referral has a high prevalence with an estimate of 21% of all adults undergoing audiologic assessment. Urban et al. Reported that in 1999. So one of the major finding in history, as well as in the diagnostic tests that we do, is a unilateral hearing loss or asymmetrical hearing loss. Both asymmetrical or a unilateral hearing loss will have to generate differential diagnosis of acoustic Schwannoma and should be ruled out through testing. There is and should be a role for ABR screeners as we already. Now, when we go to the same ABR, if we go towards the one of the major, as I said, finding for retrocochlear pathology was acoustic Schwannoma. The other effect, we will go to its details of how to diagnose it a little later in some of the other lectures. But effects of cochlear hearing loss on the ABR are different. The effects of the cochlear hearing loss depend upon the degree and configuration of the hearing loss. But as you know, when we do the ABR, we measure two things. One is the latency, other is the intensity. They are normal latencies at certain intensities. They are compared, they are available as norms for that age group and that latency, that intensity. The latencies are measured. But in a cochlear hearing loss, so there will be a difference between wave 1 and 2, 2 and 3, 3 and 4, 4 and 5. These are called intraoral or intraoral wave latency differences. Now, if we compare these wave latencies with the contralateral ear, they are called interoral wave latency differences. So intra will be within a ear, and inter will be between 2 ears. So but the consistent observation in cochlear hearing loss is that intra-wave latency measures are largely unaffected by a peripheral hearing loss, both conductive and cochlear. Interwave and intrawave latency measures are largely unaffected. This is the crux of the matter. The normals and cochlear hearing loss, although intensity will be different. Suppose patient doesn't get the waves don't appear at 50, so accordingly he or she will have a hearing loss. So that means that intensity will determine what is the hearing loss, not the latency differences, because the latency differences intra and intrawave will remain the same. So this is one of the major findings. Moeller's ABR criteria for diagnosing a he considered it microvascular conflict of the eighth nerve. Ipsilateral, these are differences. Let me come to the, as you can see in these, at an intensity of 80 dB NHL, the wave 1 will be between the latency will be between 1 and 2. Usually wave 3 is between 3 and 4 milliseconds, and wave 5 between 5 and 6 milliseconds. Wave 4 is between 4 and 5 milliseconds. These are the norms as far as, but obviously they will exact norms will depend on the age and on the intensity. So at 80 dB NHL, those are the norms. If wave 1 of the ABR is present, decisions regarding the presence or absence of eighth nerve and of brainstem abnormality are relatively straightforward. If wave 1 is present, eighth nerve is present. Unfortunately, many patients with a moderate to severe hearing sensitivity loss do not have an identifiable wave 1 component, rendering the derivation of one or more typical interwave latencies to be unidentifiable. These, when they are unidentifiable, then we have to resort to absolute latencies. If the waves, only wave 5 is identifiable and wave 1 is not, and we have to determine the 1 to 5 interwave latency difference, intrawave latency difference, then you will have to rely on absolute latencies, which I've just told you at 80 dB NHL. So if derivation of one or more of three IWI, the intravave intensity measures 1 to 3, 3 to 5, 1 to 5 is impossible because 1 is not there. When unfiltered click stimuli are used to derive an ABR, the response is largely being generated by activity in the basal region of the cochlea. The click stimuli is usually used for doing ABR, and when that is used, the frequency emphasis is between 2000 hertz to 4000 hertz. So that will be the area of the basal region of the cochlea that it will measure, because it will be the higher frequency. Higher frequencies are prevalent at the basal region. So that's what it will measure. Since the signal reaching the basilar membrane is shaped by the filter effect of the outer and middle ears. Now, basilar membrane response is dependent upon the response of the outer hair cells of the inner ear and also the outer and middle ears. Okay. So the resonant peak for most transducers used in electrophysiological testing tend to occur in the high frequency range, usually peaking at 3 to 4 kilohertz. Because that's what, when the transducers is also peak resonance peak is at 3 to 4 kilohertz. The click is between 2 and 4. The most information that we will be able to get will be from 2 to 4 kilohertz in the basal region of the cochlea, which gives the stimulus reaching the cochlea high frequency emphasis. For these reasons, the effect of a cochlear hearing loss on the ABR can be quite variable and highly dependent on the frequency rate, whether the hearing loss is in the low frequency or in the high. If it's in the low frequency, in high is a reverse slope, you will get normal hearing responses. But if it's a sloping loss, then you will get the actual hearing loss that the patient has. And if it's a flat loss, again, you will get the actual hearing loss that the patient has. But if it's a reverse slope, less hearing loss in the high frequencies and more hearing loss at low frequencies, then you will have to do tone pip or tone burst stimuli to get information about each of the low frequencies. So the slope or audiometric configuration, flat, mildly sloping, sharply sloping, and the severity of the hearing loss all have an effect on the results that we get. The one difficulty in obtaining auditory brainstem responses from patients with high frequency hearing losses is that the hearing loss shapes the effective spectrum of the click. The result is that different areas on the different areas in the basal are stimulated depending on configuration and the degree of hearing loss, as we have already discussed. The different areas of the basal membrane in turn produce different latencies, which leads to a diagnostic dilemma when determining whether a delayed latency is due to a cochlear or a retrocochlear pathology, especially in cases of wave 1 absent. Where wave 1 is absent and you're just dependent on wave 5, then at certain times this dilemma is there, and then you have to resolve it by doing some other tests, and so that as objective tests, so that you can get a better understanding of the hearing loss. Difficulties are encountered in comparing ABR latency hearing patients to norms collected on normal hearing subjects, as well as in comparing intraoral latencies of patients with unilateral or asymmetrical hearing loss. If it's a unilateral or asymmetrical hearing loss, it will be a difficult ABR, because obviously the Intra-wave and interwave latencies will differ. And various methods have been used to compensate for the delay caused by cochlear pathology, although none has achieved widespread use because of relatively poor predictive results for individual cases. So various compensatory methods have been used, but none has really given a satisfactory answer to these dilemmas that we face. These methods include a corrective factor to the click evoked latencies. Another way to circumvent this problem for hearing impaired subjects is use tone pips in attempt to stimulate equivalent areas of the basilar memory, normal and pathological. When you are using tone pips, you're just using one tone, and that stimulates one area of the basilar membrane, giving you one response. Another potential shortcoming of reliance on MRI without UVR testing is that the ABR provides an index of physiology, which at times certainly differs from anatomical. So it will provide, ABR will provide you with the functionality of the nerve and the brainstem. ABR will just provide you with the anatomical dimensions. So that will make you the morphology, you will be able to see the morphology, you will be able to see the latency differences and how deep is the problem, how much of the patient is understanding through the nerve. All these things can be derived from the morphology and other aspects that you have with the ABR. There can be abnormal function for ordinary nerve without a problem being a space occupying lesion, such as a vestibular schwannoma or acoustic tumor. Okay? इसके अलावा भी there's other things like auditory neuropathy. So auditory neuropathy, which is a newer, which is just like a wire, a current passing through a wire, which is short. So what happens is the current is passing, but it gives the sound like, you know, a simmering sound. The same way, the sound is and the electricity passing, that it's not passing properly. Similar way, sound is passing, that it's not passing properly. Minor vascular problems, inflammations, and infections may not show up on imaging studies, but may still affect hearing. So other problems. Moreover, auditory nerve problems in many cases are handled differently from cochlear problems. So these have to be differentiated, and normal morphology, as you can see in this image, this is normal morphology. Type 2 replicates not with either wave 3 or wave 5. Type 3 replicable with neither wave 3 or nor wave 5. And number 4, as you can see, there is no response. In today's lecture, students should be able to know about the molars. Major findings, students will learn the regions of wave 1 to wave 5, some imaging issues, effects of cochlear hearing loss. We'll go into the details later on about each and every of these aspects, but this gives you an overview of how ABR can be used as an effective tool, as an objective test to, number one, most importantly, find out about the hearing thresholds, number 2, cochlear hearing losses, and also retrocochlear pathologies. And we'll go further with it. In the next lecture, we will go into the details of ABRs and their waves, and also tell you about latency intensity function graph and how to diagnose hearing losses.